May I invite our third speaker? Actually, there has been a little change in program. Initially, Mrs. Nehal Jain was scheduled, but for private reasons she couldn't attend today. But her colleague, Ms. Prakya Bhatt, will make the presentation that was initially planned by Nehal. Ms. Prakya Bhatt is working for the Center for Budget and Policy Studies here in Bangalore, and she has been working extensively for the last couple of years on issues that have to do with health financing. She's going to give us a presentation on differential financing for public health facilities. Ms. Prakya, please, the floor is yours.
Hello, everyone. I'm going to be presenting the differential financing of public health facilities, a study conducted by Center for Budget and Policy Studies in collaboration with State Health Systems Resource Center, Karnataka. This is a snapshot of the flow of the presentation. I'm going to be looking at the implication of low health spending, the background, research focus, methodology, research findings, and the recommendations. As it's a well-known fact, the health spending in India is nothing more than 4.2% of GDP, where the public sector expenditure on health is 17%, and the private sector expenditure on health is 77%. In the state of Karnataka, not more than 1% of the GSDP is spent on health expenditures. The implications of low levels of health spending is, of course, low quality of healthcare, particularly in the public health facilities, which leads to a shift in accessing healthcare from public health facilities to private health facilities, more dependency on private sector for accessing healthcare, complemented with low level of insurance coverage and increased out-of-pocket spending, which, of course, again leads to catastrophic health expenditure and impoverishment of the already poor. Under NRHM, the public health facilities are funded on yearly budgets which are fixed and uniform, irrespective of their needs and performances. So NRHM introduced this innovative approach of flexible financing to public health facilities under untied funds, ARS corpus funds, and AMG. The utilization of untied ARS and AMG funds from the very beginning have been poor, which calls for the need to rationalize the distribution of funds and allocate them efficiently. It has been proven in our study that as low as 7% and a maximum of just 60% in our sample facilities were utilized of the total funds that was given to the facilities. Although our study had focused on many research questions, around 10, the main point of focus for us was to understand the utilization pattern of untied ARS and AMG funds to identify the indicators that can be used for differential financing. The study was a cross-sectional study of primary and secondary level public health facilities in the state districts of Udupi and Bangalore urban in Karnataka. We used purposive sampling, where 46 health facilities were interviewed with 92 stakeholders. Data which related to resource performance and finance was collected for 2009, 10, and 11. This is a snapshot of the funds under NRHM to public health facilities. As we noticed that the district hospitals get the maximum of about rupees 5 lakhs a year, which includes all these three types of funds, and 2,50,000 for community health centers, 1,75,000 for public health centers, and 20,000 sub-center, and 10,000 for the village health and sanitation committees. This is the findings and the utilization pattern of our study. We found that the utilization of funds is increasing over the years, 2008, 9, and 10. With the level of health facilities increasing, the utilization of funds are also increasing. VHSCs are not able to spend as much as the CHCs or the PHCs are. This is what was stated as the biggest problems in utilization of funds as per the ARS committee, which was interviewed during our study. Here we noticed that most of them, 14%, said the lack of opportunities was a fundamental problem in utilizing the funds. And there's a lack of requirement, according to 6%, which shows a whooping 20% stating that they didn't even need these funds. So which again sells the fact that we need differential financing. A very small percentage says that a lack of awareness of guidelines and late release of funds have also been the fundamental issues which they faced, according to them, to expend the funds. In our study, we tried to explore the link between the utilization of funds with per capita allocation of funds, the population served, number of beds at the health facility, workload, infrastructure, and etc. Limitation of our study was that it was a smaller sample size. However, we did establish some conclusions based on the fact that, facilities had a higher utilization and higher average distance from district headquarters. The average infrastructure and equipment availability is higher in health facilities having higher utilization. So we saw that there was a linkage between better infrastructure, greater distance to the health facility, and other factors, though we could not make any definite conclusions on the impact and availability of human resources, number of beds, training, etc. So this is a snapshot of what it was like with the population served. What we noticed is, for example, a public health facility is supposed to serve about 30,000 population, but it can range anywhere between 5,000 to 50,000. So when they're given standard and flexible financing, what happens is they're given fixed rates. So per capita expenditure and receipt can vary greatly. So the impact of per capita expenditure and receipt has been analyzed here. If you notice that the range between minimum value to maximum value, for example, for primary health facility, minimum has been 5.2 per capita, while it has gone up to 26.4 rupees per capita receipt, and likely the same with the per capita expenditure, where 5 rupees to 14.9 rupees, which doesn't really make sense because at each level of the health facility, you need a fixed amount per person depending on what disease or problems he's coming with. So the implications of this is, of course, that uniform pattern of funding is discouraging the health facilities who are spending funds, and funds are lying unutilized in facilities that are not able to spend the funds. Therefore, a strong need to introduce differential financing, which will lead to rational, effective, and efficient utilization of limited available public resources and helps them use it more efficiently. We propose this formula, a simple, basic formula for differential financing of untied funds and ARS funds. Thank you very much.
Thank you very much, Ms. Prakya, for keeping in time, but mostly for this interesting presentation on the use or lack of use of these public funds, untied funds that are allocated to district and health facility level.